Well, that was really a very wonderful and concise review of the pathophysiology of autonomic imbalance in heart failure and how autonomic imbalance can be rebalanced with barostimulation. So you now see the mechanism of action of barostimulation as reviewed again here on this slide. So now let's look at the clinical consequences of this rebalancing of the autonomic nervous system. And much of what we know about the clinical effects of barostimulation comes from the BeAT-HF trial, but I just want to mention that there were additional studies performed before this pivotal trial that really provided the proof of concept and ultimately the preliminary clinical data to move on to this pivotal trial called the BeAT-HF pivotal study. This study was really the first to receive admission to the FDA's breakthrough device pathway. And so it was performed as shown on this slide in two phases. Patients who were optimized and stabilized on guideline-directed medical therapies underwent a baseline assessment, and then they were randomized 1-to-1 to receive ongoing optimal medical therapy alone or ongoing medical therapy plus barostimulation. And you can see that there are really two key time points here in this study, a pre-approval and a post-approval phase of this study, during which the effects of barostimulation were assessed initially on short-term symptom improvement as well as safety, and then ultimately on long-term symptom improvement and an examination of harder clinical outcomes. And I should mention that based on the conclusion of the first phase of this study in August of 2019, the FDA approved barostimulation for the treatment of class 3 or recently class 3 heart failure patients, demonstrating an improvement in 6-minute hall walk, quality of life, New York Heart Association class, NT-proBNP, and safety through 6 months of follow-up. So now I'm happy to share with you more recent data that comes from the extended phase of the BeAT-HF trial, looking at the durability or sustainability of these symptom improvements. And you can see that not only are these improvements sustained, but the magnitude of effect is large, even over 1 or 2 years of follow-up. For example, at 1 year, there is a between group improvement in the 6-minute hall walk distance of 44 meters. This compares very well to the standards set by other device-based therapies, such as cardiac resynchronization therapy, which are shown at the bottom of the figure for comparison. Quality of life at 2 years using the Minnesota Living with Heart Failure questionnaire, the between group improvement 10 points. That's twice as good as what is considered a clinically meaningful improvement in this quality of life score, and on par with the quality of life score seen with cardiac resynchronization therapy in patients with wide QRS complexes. And then finally, you can see, looking at a responder analysis for New York Heart Association class improvement of 1 class or greater, there's a much higher proportion of patients who improve their New York Heart Association class and in a sustained fashion with barostimulation than without it. Now, this slide really summarizes all of the major key evidence from the extended phase of the BeAT-HF trial. And I'm going to work my way from bottom to top here rather than top to bottom, and first conclude that the totality of evidence favors the use of barostimulation as a treatment for heart failure patients. Remember, these are patients with class 3 heart failure who have recently had class 3 heart failure, who are on GDMT but still highly symptomatic. They want to feel better. They need some improvement and a durable improvement in things such as exercise capacity, functional status, and quality of life. And you can see at the bottom of the slide, looking at long-term symptom improvement, at 6 months, at 1 year, and at 2 years, the durability of the effect and the magnitude of effective barostimulation on these parameters. Now, if we go back up to the top here, you'll see the primary endpoint of the extended phase of BeAT-HF was a composite of CV mortality and heart failure morbidity, and that endpoint was not met, but additional analyses looking at all-cause mortality demonstrated a strong trend. The p-value here is 0.054 towards improved mortality, inclusive of LVAD and heart transplant. And the hierarchical win ratio, a composite score evaluated hierarchically, was also positive, here statistically so. And I'll go into that a bit more on the following slides. And then finally, you can see that long-term safety has been demonstrated. So first of all, here's the mortality outcome. Mortality essentially free of LVAD, survival essentially free of LVAD or transplant. And you can see that there was a 34% reduction in those treated with barostimulation, with that nominal p-value that neared clinical significance. So we can call this a strong trend. We can't call this a significant difference. And then let's come to this win ratio. If you haven't heard about it yet, this has become a very frequently used approach, endpoint to device clinical trials, where one analyzes in turn multiple endpoints in a composite, and in this case, from mortality to LVAD transplant to heart failure hospitalization, and finally quality of life score. And I don't have time to go through this methodology in great detail, but suffice it to say that it calculates the numbers of winners or losers at each stage, and of course ties. Then you move down to the next level of the hierarchy, and then it comes up with a composite of total wins for the treatment arm over total wins for the control arm. And in this case, there was a statistically significant 26% improvement in patients treated with barostimulation. What does that mean? They were 26% more likely to have benefited across these measures of this composite score with barostim than without barostim. And for time's sake, I'm going to skip through a deeper discussion of the win ratio, but suffice it to say that this 26% treatment effect compares favorably to other trials in cardiovascular medicine that have demonstrated a positive result using this approach. For example, the Paradigm-HF trial demonstrated using this same approach a 27% benefit. So this is a clinically significant benefit according to the win ratio. And statistically significant as well. So the other thing I wanted to share with you, because I get asked this question a lot, is does barostimulation lower blood pressure? And the answer is in heart failure patients it doesn't. In hypertensive subjects it does, but in heart failure patients blood pressure remains stable throughout treatment. So you don't magnify the hypotensive effects of GDMT or produce hypotension through this form of therapy. So I hope what I've shown you here is that barostim improves heart failure symptoms, and it not only improves heart failure symptoms at 6 months, which served as the initial basis of approval by the FDA, but it also improves symptoms in a durable, sustainable way through at least 2 years. And so for your patients with class 3 heart failure who are still struggling with symptoms, this is a very good alternative for you to consider. And you're going to hear more about that from our subsequent speakers. Now, I did want to just put this in the context of other therapies before I conclude. And you can see that GDMT really doesn't have very much effect on improving exercise capacity or symptoms or quality of life in heart failure. Here we're looking at exercise capacity, and you will see that there are really very small, generally statistically insignificant, or when statistically significant, clinically meaningless improvements in exercise capacity seen with GDMT. It's really been our device therapies that have improved symptoms markedly. And you can see CRT, those patients with a class 1 indication having about a 19% improvement in exercise capacity, and Barostim produces almost exactly the same improvement in exercise capacity. So with that, I'll conclude my formal comments. We'll move on in our program, and I look forward to our subsequent discussion afterwards. Thank you.